Achondroplasia is typically diagnosed shortly after birth, but increasingly in the last trimester via ultrasound detection when the ultrasound specialist is measuring its circumference and the length of the femur and compares that on growth charts. Then, of course, that requires, if it's done prenatally, it requires genetic diagnosis after amniocentesis. Achondroplasia is a genetic condition in that it results from a single amino acid mutation of the FGFR3 receptor. Such a mutation, it appears sporadically. It's not something that is typically inherited, or for the most part is not inherited, but is found in a newborn child thanks to a de novo mutation, or a mutation that happens at the level of the germline, which is basically at the sperm or the oocyte. So 85% of the time, the parents of a child with achondroplasia do not have achondroplasia, and 50% of the time, they do when it's inherited in a Mendelian fashion. The only treatment that is currently utilized to increase the stature or the height of an individual with achondroplasia is a type of surgery called limb lengthening surgery. This is a pretty invasive surgery where individuals are subjected to a fracture of the long bones, specifically the femur, the tibia, and the humerus. And then external fixators are positioned to then stretch apart the two ends of the bone about 1 millimeter per day, and then achieving, with this process, a sort of artificial bone growth. And you can gain somewhere between 20 and 25 centimeters by means of this procedure, but that requires 3 to 4 surgeries, and it's typically done in children from the age of 7 or 8 to the age of 15. So it does require very intense preparation from a psychological, from a rehab standpoint, and of course a very strong follow-up after that. This procedure is not without a risk. It has a number of complications, infections, orthopedic complications that are associated with it, and it does not address the achondroplasia-related complications.